Organized. Well, the sad news is I think it's closer to 30 years practicing since my fellowship. Okay, can you hear me? Let's organize the slides. So, just listening in the hallway around the coffee table, it sounds like we got a pretty smart, educated group. So the original model for today is a review of the fundamentals. And I'm sure that many of this, much of the information I'll share with you will be review for a lot of you. And hopefully what I'll be able to do today is spend less time on the slides, on the research, and try to share some of what it's been like 30 plus years when I started kind of hiding what I do, you know, because there were people losing their license, particularly in California, for doing food allergy testing 30 years ago. So people had to find me out rather than putting a sign out and saying I was practicing integrative psychiatry. Well, times have changed, and it really, obviously, we need to thank Great Plains and Laurie and Dr. Shah for kind of holding this vision. I think we had 40 people registered year one, 50 with all of us, and now there's over 500. So the times are changing. Now nobody needs to hide. We're giving grand rounds in academic institutions. Many of you are from academic institutions, and what I hope we can start doing is really changing and transforming psychiatry so our patients can get the benefit of the work that we're doing here. So let's see how to start. So disclosures, I talked for Shire on binge eating. I consulted Pure Encapsulation and Great Plains, and since this slide was done, JMAC Pharmaceuticals, I've done some consulting for them. So I chose just talking about B12, folate, and SAMI today as something, particularly for those of you new, that are simple, that you can leave here knowing hopefully everything there is to know to affect patient care. And I do believe if we understand as clinicians and help our colleagues understand these few things, understanding folate, B12, SAMI, MTHFR variants, and methylmalonic acid, that we can change lives. It's really that simple. So I'm going to share two stories to start. And one is Jane, 16-year-old girl. A lot of my work is inpatient psychiatry, inpatient eating disorder work. She was admitted multiple times, multiple hospitals. She was in our hospital awaiting state hospital, long-term placement, primarily depressed, self-injury, chronically suicidal, multiple attempts. So when she got to us, she's on a lot of meds, she's stayed in bed, and we just said, did you look at genetic tests? Did you look at an MTHFR? Did we get vitamin B12, vitamin D levels? So she had the variant we'll talk about, the TT polymorphism for MTHFR, and she had a B12 level under 200. So with B12 injections 3 times a week, with L-methylfolate, over the course of a few months, this woman got to go home and not go into a state long-term psychiatric hospital. When we talk about treatment refractory depression, I hate the word because we're blaming our patients, not us, but so many of those entering our hospitals are individuals with these variants. So we change lives all the time by doing a cheek swab and a blood test. But then I just want to tell you about Jane. So Jane was a 50-ish, I don't know her exact age, but I know she was over 50, and I had treated her daughter for ADHD. Done well. She called an appointment for herself, did our routine test. So she had the same genetic variant, TT polymorphism and low B12. So as a clinician, I get kind of excited because I know that person's going to feel better. So what happened to Jane? She presented as anxious, depressed, tearful, not sleeping, classic symptoms of major depression. So I was confident that she was going to feel better. And came back, B12 shots, didn't feel better. Next month, I don't know what we did, but we kept trying. And I don't know if it was 3 or 4 months. It was a while. She was able to sit and tell me that she was in an abusive relationship with her husband. And part of my message this morning is we get very excited about our ability now, and that's what's so important to me about this conference, about taking psychiatry out of this vague, measureless, medicine-educated guess world into looking at objective findings. And that's what we can do with some of these genetic tests and some of these vitamin and mineral deficiencies. But if we don't ask or understand about trauma and someone's relationships, some B12 injections are kind of meaningless. So identical lab tests, very different stories. The good news, she got to a therapist, she left her husband, and she's doing well. But we can't always rely on lab tests, and one of my new mantras whenever I talk is we don't treat lab tests, we treat patients, and we got to remember that. So, okay. So I'm also going to keep this into very simple, and somehow through the course of this time, we're going to go through the ABCs of integrative psychiatry. So the A was ask. Ask about trauma. It's not always something that's easy to talk about. The B is just as important. If you don't test, how do you know? So 5 individuals walking into your office with identical symptoms. We're here because of our frustration with that symptomatic-based prescribing world that many of us were trained in. Can I digress for a minute? How many psychiatrists? Good. Okay. How many non-psychiatrists? Okay. Back to Debbie. So same symptoms, right? So we complain that, Prozac, depression's not a Prozac deficiency, or anxiety is not a Xanax deficiency. But my worry about our field, and that's what we got to get to say after 30 years, our field is that we're often doing the same thing, and I'll talk about that as we go through B12, folate, and SAMI. But identical symptoms, Debbie, Deborah, Debs, they're anxious, they're not sleeping, they're having anxiety attacks. And if we jump to our integrative, symptomatic-based I'm going to give them 50 milligrams of 5-HTP. I'm going to give everybody folate or everyone B12. That's not what integrative psychiatry should be, and we need to test. And the second in the ABC, if A is asked, B is biochemical individuality. It's the core principles of integrative medicine. Oftentimes we forget it as we kind of jump to that quick fix symptomatic approach. Okay? Same symptoms, different etiologies. We need to understand it. Part of what I need to do today is, because you have the slides, go through some of these quickly. I think we should thank Heather for putting this on, but she's so organized. We send her the slides like a year in advance, and oftentimes we don't need all the slides. Okay, neurotransmission. I think we know that. Let's keep going. The fatty acid cell membrane. How many people have read The Biology of Belief? Okay, 10th year anniversary, but it was just a nice model of his description of the cell membrane as actually the brain and how everything gets regulated through the membrane. So all our fats are critically important, and Dr. Shaw will be talking about. But it's also important because of our epigenetic concepts. It helps regulate what goes in and out of the cell membrane. And we know that individuals with mood disorders and multiple psychiatric disorders have different methylation profiles. and these inflammatory genes are affected by these methylation profiles. I'm not sure. Okay, here we go. So we know what methylation is. So multiple enzymes and genes required to work together. We're going to try to get to those today. And why does methylation matter? Because critical roles in the synthesis of neurotransmitters, most of what we're going to talk about, breakdown of neurotransmitters, and multiple kind of epigenetic regulatory functions with genes. I don't know if this needs another battery, but it's not. There we go. Okay. So the reason I put the term mania in at the time, whenever I set this up, is I was just getting concerned that every patient walking in the office who has a computer and on the internet is concerned that their problem is due to methylation problems. And it's not only our patients, I think it's many of our practitioners. And it's kind of maybe overtaking gluten as the latest cocktail hour discussion, right? I mean, it's hard not to have a conversation with colleagues where methylation comes up. And I wish it was that simple, and I use the term mania here only in that people, I believe, are overestimating the understanding of how methylation fits into the treatment of complex mental health problems. These are some examples, and we're not going to go through those. But I want to start with the first methyl group. Where does it come from? We need to obtain this from our diet, and we get it from folates. Okay? And we all familiar with the term folic acid, but folic acid is not a natural nutrient, right? It was synthesized in a lab. It was synthesized by a pharmaceutical company. So we got to be a little skeptical to begin with. But somehow it was this very stable molecule that if all things are in order, we can transform or make it into all the other variations of folate I'll talk about, including L-methylfolate. But it's really important to understand that it's a synthetic vitamin. And as a synthetic vitamin, I think there's a talk maybe at the end about some of the concerns about folic acid and the buildup of folic acid. How many people have read the autism, the Alzheimer's, the cancer associated with intake of folic acid? I think it's important. I think the literature is a little confusing. It's not really clear to me. But folic acid is a synthetic nutrient that's added to our multivitamins and added to our food, flour. And that's incredible good news in many ways because it had a tremendous benefit in decreasing neural tube defects, as we all know. I just use a chart like this to demonstrate the sad reality that I guess I've lived too long to experience is what happens when there's a nutrient discovery that might affect health. What's the lag time? 18, 20, 25 years. What's the lag time to get a pharmaceutical drug to market with 200 patients with only 2 deaths in the trial? That gets approved, within a year. But some of our nutrients, and folate is just one example. So we have the ability, and someone calculated how many babies we could have prevented with spina bifida if folate was recommended in the 60s, late 60s or 70s, when this information was coming out. It took 18 and 20 years later for our colleagues to say, oh, maybe a nutrient could provide tremendous benefits. So we knew folic acid as a synthetic vitamin made a huge difference for neural tube defects. But what we're looking at in terms of psychiatry is the transformation of folates in our food supply or folic acid as a synthetic into L-methylfolate. L-methylfolate is a form that crosses the blood-brain barrier, and L-methylfolate is the form that's required in the rate-limiting step for the synthesis of our major neurotransmitters, dopamine, serotonin in particular. So what we're going to talk about is some of the genetic variants in this metabolism. But first I want to get to all this folic acid in our diet. How many people look at blood tests for folic acid? And how many people get low levels? Only a few. And we're going to talk about the studies with low levels. But most of the time, the blood levels of folic acid are really high. And it's particularly striking for me working in an eating disorder facility where mostly I'm treating anorexic patients who haven't eaten very much for months or years, and they have high folate. So the high folate in our serum that we're often seeing is this unmetabolized folic acid. So we're not able to kind of break it down. It kind of affects the receptors at the blood-brain barrier, so it kind of blocks the receptors, so L-methylfolate's having a harder time to get in. And that's why we're seeing all these high levels. So I have lots of people calling me, talking about, I have these high levels, so I can't use folate. Well, again, our blood tests are measuring L-methylfolate and all these different variations of folate that you saw on the last slide, folic acid and L-methylfolate. So we're getting these large numbers. They're clinically likely meaningless in terms of how someone would benefit from supplementation with folate. Okay, so first test point, folic acid accumulates in the blood. It's not converted. We get high levels. Those high levels are not necessarily meaningful at all in terms of supplementation. So risk factors for low folate, we could have used this slide and 10 other slides, but it is common. I mentioned trauma. We'll talk a little bit about that, but trauma, inflammation, increases need for L-methylfolate. Most of the medications we're using in psychiatry affect folate metabolism. I made a joke about celiac disease, but certainly our inflammatory bowel diseases and our gut issues are rampant and increasing and affects the absorption of folate. Alcohol, smoking, dietary intake and fads, aging, and then our genes. So we'll talk about a couple different genetic polymorphisms for the MTHFR gene, and body mass index. So some of the things that we know, there's a higher need for folate as BMI increases. So I started getting interested. If I've been practicing for 30 years, somehow, I don't know, maybe 8 years before that, in medical school, I did a paper on folate and depression. So we're talking about 35 years ago. We had literature and research that showed low levels of folate associated with depression. This is not new. This is just a meta-analysis of over 15,000 people with just the facts. Low folate is associated with depression. And then over the years, we refined that information. The next few slides come from Harvard Medical School, Mass General, where they did a lot of work. Here, folate, low folate, associated as a predictor of response. So here you see those that had low folate had a 71% response rate, and this is with Prozac, pharmaceutical. And then normal folate, much better response. So it's easy when we look at some of these older studies, because again, we got low folate levels a lot. And for some reason, maybe it's the multivitamins that people are taking, but we're not getting as much low folate. It doesn't mean they won't benefit. So predictor of response, and one of my favorite studies is predictors of relapse. I mean, for those of us treating depression in particular, we are typically talking about a chronic relapsing illness and might get some benefit from particularly our standard pharmaceuticals, but the relapsing course is certainly part of it. And so here, low folate predicted relapse, and it's pretty dramatic. If you had normal folate, right, there was 3.2% chance of relapse versus almost half with low folate. So we have predictors of treatment response, predictors of relapse. So again, we're talking 30 years, but we work slow in psychiatry, particularly with nutritionist psychiatry. So we started looking at studies. And we didn't look at studies when it was a vitamin, right? Because that doesn't make sense. It's too cheap. It might be helpful. There's no profit. But all of a sudden, we started getting the doses a little higher. We got some pharmaceuticals involved, and then they could fund a few studies. So we started looking at higher dose L-methylfolate, and we got some positive results as an augmentation strategy for SSRIs. Individuals improved. And then another study published in the American Journal of Psychiatry, 15 milligrams of L-methylfolate plus the SSRI. God forbid we do a study with just a nutrient, right? And if we did, it wouldn't get published in some of these journals. But, you know, we take what we can get. So folate kind of got on the map. These are some of the earlier studies, and there continues to be newer studies. So you have those. And, you know, a lot of the work has been with depression, but when we get to some of these MTHFR variants, we will see literature on autism and schizophrenia and substance abuse, OCD, anxiety, the full spectrum of major psychiatric illness. Okay, so why is folate so important? Well, we have the synthesis of our neurotransmitters, dopamine and serotonin, and these are these precursor amino acids, the phenylalanine and tryptophan, are obtained from our diet. So we need to be eating enough protein. So we have to be careful about our adolescent vegans. And we need to have enough acid in our stomach and digestive enzymes to break down the protein. But then we have a series of steps that require nutritional cofactors, vitamins, and minerals. And folate happens to be part of that rate-limiting step, meaning without adequate folate, this synthesis of these neurotransmitters aren't going to continue. So we have the rate-limiting step for dopamine and norepinephrine, and the rate-limiting step for serotonin synthesis. So what we try to understand is that folate is so critical for methylation of these neurotransmitters, and the methylated next molecule is SAMe, and we're going to talk a bit about SAMe at the end. So folate adds a methyl group to make SAMe, and SAMe then provides a methylation for all the major catecholamines. So as folate goes down, you can see SAMe goes down, and homocysteine levels go up. We'll get to that. Impaired methylation, less neurotransmitters, and then as folate becomes supplemented, we're going to decrease homocysteine, increase SAMe, and back to more optimal synthesis of the neurotransmitters. This was a diagram actually taken from the American Journal of Psychiatry probably about 10 years ago, as they discussed this as a theoretical option for the treatment of depression. So we're all aware, and so I'm not going to go through the single nucleotide polymorphisms. We know what they are. They are the core of the B in the ABCs we're talking about, the biochemical individuality. So you have that. We know things don't work. And what we want to talk a little bit about is MTHFR, and there'll be talks about COMT. So I don't know how one can practice psychiatry or treating mental health without having an assessment of MTHFR. To me, it's that important. And it has profound implications. The treatments are simple, safe, and cost-effective, and with a real clear model for prevention. So there are a couple different variants of the MTHFR gene, the C67T. There are 3 variants. We're all familiar, CC, CT, and TT. and has profound implications for how efficiently we can metabolize the various forms of folate to L-methylfolate. Okay, and then the next gene, the A1298C, there are also multiple variants. And this is what I want to get to, is how do we understand what these variants mean? The three variants, I think the incidents in the community are really important. Some people don't realize that the CT variant is the most common. The two numbers there are just different studies. So it's somewhere between that 45 and 56%, CC and TT. But one of the simplest ways of remembering or how we can talk to our patients is this concept of, you can see on the right, the guy lifting weights. We're trying, but how about T is for trouble? Okay? Pretty simple. So let's try to understand it. If your patient has 1T, CT variant, there's a 35% decreased efficacy in converting folate to L-methylfolate. 1T. If we have 2 Ts, as the two patients I discussed earlier, we have a 70% decrease in converting folates to L-methylfolate. Okay? If we go back to our the 1298C, it's, actually that's not right, it should be 20% less active. Okay? So you're never going to get over 100%, but you're going to get different variants affecting the efficacy of converting the homocysteine, the folate to L-methylfolate. And L-methylfolate is the form that we need to make SAMI to make the neurotransmitters. T is for trouble. Now, what I'm going to talk a lot about this morning is the genetic testing. We've got a lot of companies out there that's helping us understand the importance of genetic testing. But by itself, it is a vulnerability. It doesn't mean anything. There are plenty of individuals in this room with TT, and they feel fine, right? And I know patients and staff. We did, our profile on all the staff of the hospital, and there were some TTs without clinical symptoms that we're aware of. But it's that environmental genetic kind of dance that we're always talking about when we're talking about clinical symptoms and treatment recommendations. So again, old studies, but pretty relevant, and we see it also in the other literature, from schizophrenia to substance abuse. But these variants have dramatic implications for the incidence of depression, most of these things. So if you have the TT, you have double the risk of depression. Now that's just having the genetic variant, but what if we start throwing in some of these other variables that we look at and that we ask about? It could be trauma. It could be another nutrient deficiency. It could be gut. It could be a food allergy. It could be a whole host of these factors that could be contributing to creating the symptoms our patients are presenting with or creating the need for nutritional support. So I just kind of threw this slide in for nostalgic because this was like 100 years old, but it was the slide that helped me understand this many, many years ago. So folate's also important for DNA repair, right? We're not just talking about requirements for neurotransmitter synthesis. So this was just a study that looked at the amount of folate required to repair DNA based on the different gene types, CC, CT, and TT. And it can just see the 3 times the amount of folate required for the TT in DNA repair. So besides being a visual, it also kind of helps us understand the importance of folate is not just for the synthesis of the major neurotransmitters. So here's just kind of a summary. Regardless of the cause of folate deficiency, dietary, genetic, drug-induced, we're seeing a lot bariatric surgery. How many people are seeing individuals post-bariatric surgery, which is increasing pretty dramatically? And it is a rapid train to nutritional deficiencies. We see a lot of patients having an eating disorder program. So many of these patients, they feel so good about the weight loss, they really do not follow through with their nutritional supplementation. So they might take their vitamins for 6 months, but without being able to absorb particularly nutrients like folate, we see higher incidence of depression, substance abuse, suicide, and gambling is a big one. So post-bariatric surgery, there's major psychiatric complications. Much of it, I believe, I don't think my surgical colleagues are with me, are due to these nutritional deficiencies. Okay. So we have DNA repair, neurotransmitter, and multiple variations in oxidative stress and CNS disorders. And then just new research, and I think we continue to see it coming out on prenatal folate, psychosis, autism. So huge research initiative of now of folate in major mental illness. So I wanted to take a minute to talk about inflammation. I think it touches on a lot of the talks over the next 3 or 4 days, but somehow inflammation as a cause of depression has made it through the academic world of psychiatry, so it's kind of a hot topic. Why is it a hot topic? Because we can make drugs, right? We can have anti-inflammatory drugs, so we have lots of old anti-inflammatory drugs being looked at for the treatment of depression, but a new drug pays more, so now we're developing anti-inflammatory drugs for the treatment of depression. So the good news is that inflammation clearly is related to depression in some individuals. We know the inflammatory cytokines can cross the blood-brain barrier, can affect tryptophan, can affect serotonin, and can create the symptoms of depression. But just like the kind of methylation mania, there's an inflammation mania where everybody who comes into your office must have inflammation, and they have to go on the anti-inflammatory diet, and they have to take these anti-inflammatory supplements because that's the cause of depression. Well, it's not, right? B, biochemical individuality. But there are clearly some individuals that are walking into your office with symptoms of major depressive disorder, and you're going to see elevations of inflammatory markers, whether it's CRP, ferritin, or if you do cytokine levels, and you're going to be able to treat inflammation. And they're going to get better. Hopefully you'll be able to find the source. Is an underlying Lyme disease, vitamin D deficiency. We're looking always for the source. But the punchline here, we're talking about folate, is inflammation increases that demand or that need for L-methylfolate. Okay? Regardless of the cause, inflammation is going to increase the demand or need for L-methylfolate. So again, I'm painting this scenario. Somebody is TT genetic variant, but life is going okay. They develop Lyme disease or another illness. And all of a sudden there's inflammation and that oxidative stress and all the associated things kind of creates that vulnerability, and major symptoms develop because of inadequate folate for the methylation of the neurotransmitters. Okay, so now we're going to jump to homocysteine. I think I want to jump to this slide first. Why are we worried about homocysteine? Because elevated homocysteine is likely associated with most of our major neurodegenerative, neuropsychiatric illnesses. I've been looking at this for many, many years. And besides depression, schizophrenia, Alzheimer's, Parkinson's, cardiovascular disease, I've seen incredibly anxious panic attack patients. Just had a case recently, a 16-year-old gentleman, as homocysteine comes down, really debilitating anxiety, completely eliminated. So it's associated with all of our major neuropsychiatric illnesses. The mechanisms are theoretical, but there's multiple mechanisms. But as homocysteine goes up, we have major neuropsychiatric illnesses, and to decrease homocysteine, we're looking at our folate, B12, and B6. And let's keep going. And it's hard not to start with a discussion of Alzheimer's, because again, similar to our folate and neural tube defects, we've known about homocysteine association with Alzheimer's at least since 2002. So New England Journal of Medicine, the Framingham Heart Study, increased plasma homocysteine, independent risk factor for the development of dementia and Alzheimer's. Pretty good getting in the New England Journal of Medicine. I don't know, we read it, but it was kind of nutrition related, not drug related, because the treatment is pretty inexpensive. So probably not a lot of press, but hopefully we'll get more press. This was an international consensus group looking at homocysteine and dementia. So clinicians from around the world gotten together, looked at the hundreds of papers and said, oh, wait a minute, elevated homocysteine is a risk factor. And more importantly, it's a modifiable risk factor. It's something that we can do to help our patients in a preventative strategy. And so much of psychiatry ignores the concept. So much of medicine ignores the concept of prevention, but psychiatry in particular. So homocysteine and dementia. And here, from that article, B6 should be part of it, as B6 is often required as well. Oh, this was interesting, that for this consensus study published this year, that it was moderately raised homocysteine, greater than 11. How many people check homocysteine? Okay, so, 11 is pretty common, so moderately raised homocysteine as a cause of age-related cognitive decline. Okay, so why would homocysteine be elevated? I'm talking a lot about folate and B12. I'm going to talk about B12 in a minute. But let's talk about B6. It doesn't get as much respect as it should. It used to in the old days, the autism literature, and there's a lab, THA labs out here looking at pylorrhea. So a very, very common, we're seeing a common, I'm not sure what the percentage is, but it's often missed. How many people check for pylorrhea? Okay, so a few people should raise your hand at the end of the conference, because pylorrhea is this genetic defect, and you bind B6 and zinc. So you develop slowly chronic deficiencies. And when someone has an elevation of homocysteine, we might be looking at folate, we might be looking at B12, but providing just B12 and folate is not sufficient. We often need to add B6. And if pylorrhea is a factor, we're looking at 100, 200. There's some individuals I needed 400 milligrams of B6 to bring down homocysteine if it's related to pylorrhea. Okay? So let's take a step back. Pylorrhea, genetic vulnerability. These pyrols bind B6 and zinc. Deficiencies of B6 and zinc have profound implications for neurotransmitter synthesis and the elevation of homocysteine. We've been taught for years, right? What's our maximum dose of B6? 100. So that's what we said, because after over 100, we would get a neuropathy and tingling, and we shouldn't do that. So I had this magic number in my head for years until I started getting well, what happened was an accident. A mother had 2 different B6 supplements, and the girl took a total of 400 milligrams. She was completely better. And this was probably many years ago before I was doing routine testing for pylorrhea. So she got better, and I panicked. I said, Mrs. Smith, we have to cut the B6. She could develop side effects. So we cut it slowly because she really did notice dramatic change, and she developed symptoms, anxiety, agitation. She was diagnosed bipolar. She obviously didn't have bipolar. So we went back up to the 400, and then I've seen her for many years. Another point in time, I tried the same thing to decrease the B6. She required 400 milligrams of B6, and it was in between that where we tested for pylorrhea. So B6 is critically important. Folate is critically important, and we're going to now talk about B12. Okay, so B12, I don't know, I might say this too much for lots of nutrients, but today I'll say it for B12. Probably the single greatest tragedy of modern medicine. Okay, the inadequate testing and the poor treatment of B12 deficiency. It's one of the simplest things that we can do, and has made the most profound differences in lives of patients. So let's try to understand it. First of all, we got to go back to this concept of biochemical individuality, because we could have 10, 20 individuals with low B12, and you might get a couple with fatigue that we would read about. You might get a couple who are depressed, and you might get a few that are anxiety and panic attacks, and then you might get individuals with neurological symptoms. You might get cognitive decline symptoms. So depending where the symptoms appear, who's the doctor you're going to go to. So you might get this early diagnosis of MS. So it's the next slide, multiple symptoms. And this is just the literature. Again, we're not going to get a lot of literature. Why? It costs a few pennies, and no one's going to do it. But these are just old studies. But they're mostly case studies, but you got psychotic depression and postpartum depression, psychosis. It's just kind of all over the literature. I think there should be a mania, so adult mania, adolescent mania, B12 deficiency. So we have multiple symptoms of B12 deficiency. And here's kind of a summary of what I see every day, and thousands and thousands of patients. The good news about being a medical director of a hospital is that we have 300 patients in our care at any one day. So I get to see the labs on many more patients than I could see if I was working in an office. So I consult with many doctors and nurse practitioners, particularly on the challenging cases. So thousands and thousands of B12 cases, and these levels don't reflect exact symptomatology. So what do? First of all, we need to test. And what's our norms? Again, the tragedy for me is the norms that particularly our primary care doctors are looking at. Depending on the lab, it might be 220 or above is normal. Some labs are 180. I've not met anybody who's felt well with B12 levels under 500. Okay? Just my unresearched rule. Someone shared with me, I haven't done, I don't know if anybody else knows, but levels in other countries, particularly Japan, normal levels are over 500. All I know is that these 200-300 levels of B12, and they go to their PCP, and the PCP says, you're fine, it's a normal level. When the patients come to see me, well, my B12 is normal. Can I just look at the lab? And it was 228, or it's just 1 point above normal. And again, my first slide, their lives are changed by B12 injections. I mean, it is really that simple. So I treat everybody under 500. I certainly would treat every vegetarian or vegan. And one of the important points that I think that was made a number of years ago, but maybe I was forgotten, is the levels of B12 in our serum does not reflect the levels of B12 in our CSF. How do we know that? Because there's one study I've been quoting for 100 years. Geriatric patients, they did spinal taps. They were developing cognitive decline, memory issues. They had normal serum B12. So small number, 10, 12 individuals, they did spinal taps, and there was absolutely zero CSF B12. Okay? So it's simple, it's safe. We can treat B12 based on clinical symptoms, which I think we should do every day, but certainly checking blood levels and treating everybody under 500, we can also do every day. The reason the serum B12 might be normal or even elevated, how many people have seen elevated B12? Okay, and how many people, their patients or the doctors, Google it and think their patients have cancer? I can't tell you how many times a day I get a call from somebody that, you know, the high B12, it's cancer or liver disease, right? I think that's what Dr. Google says. Well, I've never seen either of those associated with it. You will get high levels if you give someone a couple injections. But what's more concerning to me is why the serum levels stay high and the CSF levels stay low. And my theory, with a few research articles supporting it, is that we need lithium, nutritional lithium, which will be this afternoon's talk, to move B12 and folate across the membrane. And you also need zinc. We're going to talk about that tomorrow morning, a little bit, zinc deficiency and anorexia, because my anorexic patients all have high B12. So these micronutrient deficiencies help bring B12 across the CSF, the cell membrane. Okay, so, you know, a classic in the field, Dr. Wright's a book on stomach acid. I still probably spend more of my time as a psychiatrist talking about bowel movements and digestion and gut health than any other part of it. But the lack of stomach acid is a big part of my psychiatric practice. Lots of reasons. Why we're talking about it here is because you need adequate hydrochloric acid in the stomach to break down and absorb vitamin B12. Okay? Some of the reasons. Again, we'll talk about it tomorrow, but zinc. Zinc is required for the enzyme carbonic anhydrase to make hydrochloric acid. Stress. Trauma. And then how about our favorite, which is our next slide? Oh, everybody on the planet is taking antacids. Even infants, right? They're giving infants, these 3-month-old, antacids. And I'm not sure what the doctors are thinking, but if the parent can't afford the follow-up visit, I've seen 5- and 6-year-olds, I've seen 9-year-olds, they were still on antacids because they were put on as a child or as an infant. So they're not stopping it. But clearly, and we have some studies looking at B12 absorption, but our chronic use of antacids decrease acid, decrease B12 absorption. So there's a smattering of studies, and you have them, and we can go through some of them looking at B12. But you know, the model here, as with folate, as with bringing down homocysteine, is a model of prevention. So here, B12 levels correlate with depression scores in unmedicated depressed patients. And our vegetarian, vegan friends and colleagues. So I guess I got to be careful what I say. But as a psychiatrist, as a child psychiatrist, I have real concerns about our adolescents' vegetarian vegan diets. It is a common part of those individuals that we're seeing with serious psychiatric symptoms, self-injury, depression, and suicidal ideation. Most of the time, our vegetarian vegan adolescents are not coming from homes of parents that have been eating a vegetarian diet. So it just means pasta and Coke for these kids. So they're profoundly nutrient deficient. And if we kind of throw that nutrient deficiency state and we add some of these genetic polymorphisms, which is common, because some of our vegetarian adolescents are going to do fine, many don't. And we have research showing that vegetarian adolescents aren't as healthy as their peers. And we also have research that vegetarian adults are healthier than their peers. So there is a difference here. And we need to really appreciate, particularly if you treat children or treat parents. Obviously, our ability to absorb B12 is mostly available from animal products. And this is, what study is this? Oh, looking at adult vegetarians. This is in Pakistan, and much higher rates of depression associated with B12 deficiency. The other thing here I want to mention, I don't have a slide, but it was in my first slide, methylmalonic acid. So for years we were taught that elevations of as B12 goes down, elevations of methylmalonic acid. You've heard that one? So we look for methylmalonic acid. It's in the organic acid test, in the urine. You can do a blood test. And oftentimes it is a nice functional marker of B12 deficiency. But I just want to share with you, it's not always the case. Oftentimes we see very low B12 with very low methylmalonic acid. I don't understand it. Probably a good Dr. Shaw question. But I've just seen it enough that we can't use methylmalonic acid as a functional indicator of B12 deficiency. When we see it, it is a marker. It's kind of that seesaw. As B12 goes down, methylmalonic acid goes up. So you have the next few slides. These are just depressed patients, normal levels benefiting from supplementation. Again, levels that are in the serum, not necessarily in the CSF. So B12 is one of the few nutrients that I use with clinical symptoms, not necessarily just on blood tests. And this I just throw in because it's fun when something gets into the official journal of psychiatry. And this was a case study of two males who failed to respond to antidepressants. They were vegetarians, low B12. So guess what? They got better. And so it got published as a case study in psychiatry in 2010. Part of the reason I use a slide like this is that all the nutrient kinds of strategies that we're just talking about, certainly folate and B12, it can be used with medications. So it's not either or. It's not taking sides. It can be used as an augmentation strategy. So I want to get to SAMI, higher B12 levels associated with better outcome. And here now we're starting to look at B6, B12, and folate as a preventative strategy for elderly depressed individuals. Again, why wouldn't we be looking at this as a routine supplement for those individuals as they get older, family history of depression, or periods of depression? Same thing, post-stroke depression is common, but we know that. Let's get to the Indian Journal of... Okay, so I just used this, 2015, the Indian Journal of Psychological Medicine, just because our hundreds of journals in the U.S. couldn't come up with a quote as poignant as important. So this was just prevention, early detection, and management of this reversible vitamin B12 deficiency state is of profound importance. So we don't get that from our U.S. journals. Okay, let's keep going. B12, older adults, same old stuff. SAMI, how many people use SAMI? Okay. How many people have seen side effects to SAMI? Okay. So a few SAMI slides, and then it's always fun when I get to read something that I read on the plane coming over here. So SAMI is the kind of the final methylator. It's been looked at for the treatment of depression for many, many years, and it's been effective. We have a number of studies. Let's see if we can find some of those. Again, Mass General, Harvard Medical School, looking at SAMI as a treatment for depression. And also, they also looked at augmentation strategies with SAMI, dosages 200 to 600 milligrams. Another study looking at SAMI going up to 3,200 milligrams compared to Celexa and placebo. So now I just want to talk a little bit about my experience with SAMI, using it for almost 30 years. First of all, I've admitted 2 patients to an inpatient psychiatric unit for mania because of SAMI. One was just taking SAMI, the other one was taking St. John's wort and SAMI. Okay? I have seen hundreds of patients who've had side effects to SAMI, mostly agitation and anxiety. So as much as I'm a fan and think it can be incredibly helpful, I think as a field, we've kind of glossed over some of the potential side effects. So the main side effect, or main concern, which was in the literature, let's say 5 years ago, is now not, is mania. So I would not recommend SAMI for anybody with a history of bipolar illness, unless you're really carefully titrating tiny doses, 100 or 200 milligrams, and monitoring carefully. And then I think with somebody with a family history of bipolar disorder, one should be cautious. The individuals that I've treated, now I've had a lot of people get hypomanic, and they love it, right? But the 2 ones in the hospital were psychotic. So again, titrating the doses. Oh, my point was one had a family history of bipolar, and one was bipolar themselves. Both self-medicated because they read something at Dr. Google. Okay? But this was, I won't tell you what the journal is because I'm not picking on the journal, but it was a holistic medicine magazine, and it was on SAMI for depression. And it described a new study, a meta-analysis. We always got to be careful with these meta-analyses. I'm not sure why they're coming out. I think, and correct me if I'm wrong, for people that are trying to publish, I think it's a quick way to get something published. So you do this meta-analysis and just put a bunch of numbers together, and you forget some of these studies. This meta-analysis on SAMI saying it's helpful for depression, a number of the studies were done in Europe, and they were IV SAMI. Okay, and I read those studies years ago, and it was so cool. It was like our ketamine excitement, but in Italy in particular, they give IV SAMI, and people got better, in days. It was kind of cool. And then they started using intramuscular SAMI, and people got better really quickly. It came over the States, and we said we can't do that, so they tried to find, the right preparations and coding to be absorbed appropriately. So they mix all these studies together. But here's what is concerning. So this is one recent multi-trial involving patients, SAMI compared to placebo. The data showed no difference between, Celexa, placebo, and SAMI. No difference between the 3 arms at 12 weeks. So the authors said, well, that's just because of the high placebo response. Okay? Now, what bothered me is this is what our pharmaceutical companies do. If we get a result we don't like, what do? We just look at different statistics to get something we like, okay? Or at least our pharmaceutical companies. So, however, in reanalysis, okay, they changed the statistics. SAMI was equivalent. And then they did a second analysis. to show SAMI was superior to placebo. So it's just a real caution as I am concerned that our integrative medicine world is taking some of the tricks of our pharmaceutical world and manipulating data to sell supplements or to try to sell safety and not really looking at the kind of clinical results. And I think SAMI is a concern. I think it's overused by the lay public, not our colleagues. If it's used appropriately, starting off low, titrating up, most of the better research, the dosages are 800 to 1,600 milligrams. So if you put someone on 200 twice a day and they're not better, we can't say it's the SAMI. You need to titrate it up. But there are individuals with family histories of bipolar, that those lower doses, 200 to 400, have made a difference, kind of improved mood and energy, and we did not have to titrate up. So I don't think of SAMI as a nutraceutical, or how about I say not as a nutrient, maybe let's call it a nutraceutical, where you just got to really kind of be careful. It can be incredibly helpful. Have you heard the term the poor boy's SAMI, which is methionine? So if we just take a little methionine, maybe a little folate and a little B12, and we shake it up, we're probably going to be able to support the synthesis of SAMI, unlikely to cause any side effects. Okay? And again, when we're talking about using something so far downstream, are we asking the question, why would SAMI be low? Is it our polymorphism in our folate? Or is it kind of amino acid deficiencies due to not having enough hydrochloric acid, and methionine, the precursor, is low? So we're always trying to ask the questions, why? So that's my SAMI caution story. 10 minutes, okay, a couple more slides. So personalized medicine, kind of that's our goal, biochemical individuality. We can really make a difference and change lives. So I think I did the A. You got to ask the questions, particularly around trauma. The B, biochemical individuality. And I didn't mention my C for today is collaborating with our patients. I think sometimes we're getting too far into the medical model and looking at supplements as the answer. Patients sometimes walk into our office and want that medication, and we need to respect that. Some patients walk into our office and don't want any medicine, but maybe they need it. So if we start collaborating, with our patients, I think we can really understand why the placebo rate is so high. Anyone know what the placebo rate is for the depression trials? 40%, 45%. So an M&M or a granola bar, we'll say no sugar. Let's just say a vitamin pill, a vitamin C pill is going to work 40, 50% of the time in some studies as good as our antidepressants. And part of that placebo response, I believe, is the faith, in taking a pill, and that's our cultural belief engine. But also part of that is the relationship, that we have with our treaters, our clinicians, our healers. So we go from collaborating, starting where our patients are. I know too many integrative docs who will not treat a patient that will not follow their prescription lifestyle. Okay? If you don't go off gluten, if you don't go off this, if you don't go off this, I'm not going to treat you. I hear that too often. So collaborating, working with the patient, inspiring that relationship and that connection, and kind of that gives our patients that hope. And really, I believe that is the healing modality that's way beyond any vitamin or genetic polymorphism. So last slide, I think. I think we have a few minutes for questions if you want. So here's my favorite line. No, let's go back to my favorite line. Nourishing the brain and nurturing the mind. So here we're doing a lot of talk here. The next 4 days we're talking about nutrients and biochemistry and guts and fatty acids, and that's great. But as I said, that relationship and that nurturing the mind, that's all the kinds of information that most of you are familiar with in terms of the spirituality and its effect on healing, our faith and its effect on healing, and mindfulness and yoga and all the other kinds of modalities for nurturing the mind are just as important. So I kind of came up with psychiatry defined as kind of my model for helping new clinicians and individuals learn this. And it's really looking at this concept that mental illness and our patients who are struggling might have multiple errors in physiology. Again, it could be that vitamin D deficiency, that candida, that genetic vulnerability to pylorrhea. And if we do these objective tests and we can understand the cause, and maybe there's multiple causes, we can really begin to use a word like cure and remission. And that is completely devoid in our psychiatric literature and our psychiatric research. When they do a depression study, right, what happens? They look for improvement in a rating scale. So it improves 10 points, and we say this antidepressant works. They're not asking the question, is your depression resolved, right? And if we did a study for ear infections, do you think we just rate the pain? Or we want to make sure that ear infection is gone. And our current model of psychiatry does not look at remission, but our integrative model really can, as well as prevention. So I will stop there.